All right, okay, good. Good afternoon, everyone. Let's get started. Welcome to the Life of the Mind. I'm Shima Wang, Vice Provost for Digital Scholarship and the Dean and the University Librarian. On behalf of the Life of the Mind Steering Committee and my co-chair, Greg Lavin, I thank you for joining us today as we celebrate UC research, scholarship, and creative output. Please note that we are recording the lecture and the panelist remarks, but we will cease recording for the open Q&A session. It is my pleasure to welcome to our Life of the Mind event this afternoon, President Neville Pinto, who would like to provide brief opening remarks. President Pinto, please.
Thank you, Dean Wang. Can you hear me okay?
Yes.
All right. And good afternoon, everybody. You know, when I saw the announcement for this talk, John, it was such an interesting topic. I quickly went to my schedule to see if I was free, and it was open, so I blocked it, and I was just supposed to be a participant. That's all I wanted. I wanted to listen to you speak, so I'm not going to take up time. I'll just take this opportunity that Dean Wang has given me to thank him for his leadership and Greg for collaborating with him to keep this alive despite the circumstances. And I think this is what a university is about. And we have such terrific faculty talent to showcase to the world, but also to learn from. And what a wonderful activity to keep going through this rather difficult period. And I want to thank my team member here, Provost Nelson. I saw her here on earlier for supporting this very important activity. So thank you everybody for participating. That's one thing that makes it easier is it's easier to get to these events. So I expect the attendance is actually pretty good. John should have a good receptive audience, and I'm sure the discussion is going to be terrific. So thank you for that. And with that, I'll turn it back to Dean Wang.
Thank you, President Pinto. And as Neville mentioned, we today also have the Provost Nelson in the audience. I would like to let Christy greeting you and say a few words. Christy, please.
Yes, thank you so much, Shimo and President Pinto. Always great to see you. Let me too just welcome everyone this afternoon and thank the team for pulling this together. Shimo and the libraries. It's always a pleasure to partnership with the Faculty Senate and our new Faculty Enrichment Center. So I think this is really a wonderful partnership that we have. The Provost Office is very happy to sponsor this event. And I just welcome everyone and would like to say how important it is that we take time to do this. We are so busy right now working our way through the pandemic as we continue to plan for other things. But these are the kinds of things that are so important for higher education. And I'm very much looking forward to the talk and the discussion today, because in terms of sort of enriching our minds and continuing to expand our understanding of these very important topics. I'm just really so grateful that we have a great faculty here to help us do that. So thanks, Shimo.
Thank you both, Neville and Christy, for joining us today. Before I introduce our speaker, John Lynch, I would like to take a moment to recognize the Life of the Mind Steering Committee who planned and organized today's event. In addition to Greg and myself, those members are Chuck Doyle, Jenny Doctor, Rita Coomer, Heather Lester, Lizzie Linwoya Scober, Melissa Cox Norris, Jenny McWees. I also want to recognize Greg's predecessor, the former chair of the Faculty Senate, Cynthia Reese, for her years of contribution in co-chairing this committee and for her continued support and dedication to Life of the Mind. Life of the Mind is brought to you by UC Libraries, the Faculty Senate, and the Faculty Enrichment Center, and it is sponsored by the Provost Office. Life of the Mind is the annual lecture series that features a distinguished UC faculty member presenting his or her work and expertise. After the remarks, A panel will respond to and discuss the lecture from diverse perspectives and engage the audience in further discussion. This fall, Life of the Mind has merged with the former author, editor, and composer to create one event that celebrates the achievement of UC's artist, author, editor, and composer. The 59 faculty and staff participating representing 13 UC colleges. Their 89 submitted works include journal articles, chapter, books, editing, poetry, artworks, and public performance. A bibliography and exhibits of those creative and scholarly works are available online. A link will be shared in the chat window here and can be found on the Life of the Mind website. We are thrilled today to present you our Life of the Mind faculty presenter, John Lynch, Professor of Communication in the College of Arts and Sciences. Dr. Lynch's teaching and research focus on rhetoric of science and medicine, especially on how the public understands science. He teaches rhetorical communication, criticism, and the rhetoric of science and research ethics. His current research projects examine public debate about research misconduct and how the scientists process and attribute authorship to the member of their research team. He recently published What Are Stem Cells? Definition at the Intersection of Science and Politics. The title of Professor Lynch's today's talk is Remembering When Medicine Went Wrong, Lessons for Medical Communication Today. Please join me in welcome to the screen Professor John Lynch. John, you have 30 minutes for your presentation before we introduce panelists to respond. John, please.
Thank you, Dean Wong, for that kind introduction. I would also like to thank the Life of the Mind Steering Committee, the Faculty Enrichment Center, Faculty Senate, the University Libraries, and the Provost Office for making this opportunity happen. I would like to share my screen, but I'm not seeing the option for that. So hold on, there we go.
It's the green button, John, is the green button.
It's telling me that the host has disabled participant screen sharing. I also gave my slides to Melissa, so if I cannot do it myself, if Melissa can take over for me and share the slides, that would be great.
Here we go.
All righty, thank you. So, as I mentioned, I appreciate the opportunity to present on some work that I've been doing looking at the history of research misconduct that I label and discuss with the phrase, remembering when medicine went wrong. This work, when you get a chance, if you can move to the next slide, is based off my 2019 book titled The Origins of Bioethics, Remembering When Medicine Went Wrong. That book studies the public remembrance of, I don't know if the sound's getting any better or not. I'm trying to adjust the headphones and the mic to optimize that, but so the, excuse me, the book examines the public memory and recollection of some of the key events that led to the birth of bioethics and research regulation as we know it today. He looks at museums and memorials dedicated to very prominent moments, to the moments that are somewhat forgotten or unremembered. And those are three cases that make up that project. The first is the syphilis study that occurred in Macon County, Alabama, known as the Tuskegee Syphilis Study, the Willowbrook State School, and the study of hepatitis there that was inflicted on developmentally disabled children at that school who were then infected with the disease. And then the least known of these cases, a study of whole body radiation exposure that occurred at the Cincinnati General Hospital. This presentation will not delve into all of the minutiae of the book, but as what I was asked to do, to take the material from the book and build up from that to talk about some key questions that I was asked, and then the implications of that memory and that history for us in the present day. And so briefly, because this is an interdisciplinary conversation, I'd like to tell you about my sort of research area, which is rhetoric and communication studies, and then move into this phrase that I've been using. What does medicine gone wrong actually mean? Why am I using this language? And then finally, I would like to talk about how we think about or talk about these issues and the challenges that started with some of these research problems and how they persist or exist through into the present day. So if we could move to the next slide.
To increase the sound quality.
I am trying to do that as best as I can. I do not, for some reason, I'm not having much success in changing that. Can anyone hear me any better now?
Keep talking, John. Keep talking.
Okay. Alrighty. So, so briefly, what is this area that I'm coming from? Rhetoric. Rhetoric is the study of symbols, by which I mean words, images, objects, places, etc., and that we do this study to understand how these symbols make meaning for us and how they coordinate our collective action and identities. When we come to understand an event, that then helps begin guiding us in knowing who we are and what we ought to do. And when it comes to the rhetoric of science and medicine, then we're looking at the multiple levels of meaning making that occur throughout scientific practice, from conversation and debate that might happen within the space of a lab, to the dynamics of scientific publication, arguments over who ought to be an author or who ought not to be an author, issues of public-facing communication that go from patient-provider communication to public service announcements and health and medical awareness campaigns, to broad public debate, which includes things like concerns about teaching evolution in public schools, to anti-vaccine controversies, to conversation about the coronavirus and its implications for us in the contemporary our contemporary sort of situation. For me, a key focus of this has always been the ethical implications of science and medical communication, which is why rhetoric often works alongside other disciplines, especially for me, for bioethics. So next slide, please. So in all of this, I became very interested in the history of bioethics, how we ended up with the types of research regulation that we have today. And I was trying to make sense of it, and I started talking about it as medicine gone wrong. And what does it mean to call this situation that way? What is in this name? And there's a variation. There are different ways that people talk about this. Most commonly, I think many of you in the conversation here might be familiar with the language of research misconduct, which comes out of institutional review boards and university and institutional oversight of them. That language covers everything from not correctly filling out informed consent documentation to fabrication, falsification, and plagiarism. The concept is so big, it becomes almost bloodless, and it's a bit bureaucratic. It doesn't get at the feelings and the ethical sort of disturbances that we might experience when we talk about something like the Tuskegee syphilis study. Research crime, on the other hand, which is a term that you see in some bioethics literature, does get at that emotional quality, but it ends up presuming too much. It presumes malice and intent on the parts of many of the scientists who did this, and a universal condemnation across time. But this doesn't fit with what we know about the history of these research events. Many of the actions that we saw were defended by scientists at the time. So when Saul Krugman, who was the man who ran the Willowbrook hepatitis study, people began protesting his work, the scientific community gathered him around him because what he was doing was so similar to what everyone else was doing. They didn't see that anything was wrong with those practices. And why? In a sense, why shouldn't they? Because what he did arose out of normal science, which I use that language as a shout out to Thomas Kuhn and his language about scientific revolutions, but also to emphasize that science generally works by rote and routine. We develop practices in medicine and science that we first learn as students and then as postdocs or as medical residents and fellows. And that research and that practice guides us. We want it to guide us. We don't want a surgeon coming into a surgery and saying, okay, today we're going to find an entirely new way to get to the spleen. No one wants that. We want that sort of routine practice. But our routines don't always keep up with the world around us. They begin to fall out of step with the evolving moral sentiments that we have in society. Next slide, please. And so changing our routines is difficult. I have a hard time stopping having my third cup of coffee. So imagine how hard it is to change the routines that are at the very heart of someone's professional identity. If you have always done medical research in a certain way, that you decide things are right for your patients and enroll them in a study, changing how that happens is going to be difficult. That change, that difficulty gets exacerbated by a number of issues. Paternalism, the sense that doctors have had for a long time that, they know what is best for their patients. And in the early 20th century, they felt that they never really had to ask because they knew. So when your patients start saying, no, this is wrong, it's really hard to hear them and to take what they're saying seriously. And those problems then are also exacerbated by issues of racism, ableism, and classism as well. So next slide. So medical scientists in the middle third of the 20th century resisted recognizing that their practices had gotten out of step with moral sentiment, that medicine and medical research had begun to go wrong. And what was required then was public pressure to make change possible, public exposure of studies. So you see here Jean Heller receiving an award from Ted Kennedy. Her work exposed the syphilis study in Alabama, and Senator Kennedy held a number of hearings on it that led to the National Research Act and then regulation. Exposés of the conditions at Willowbrook by Geraldo Rivera in the documentary Willowbrook, The Last Great Disgrace, changed how we cared for the developmentally disabled and finally put an end to the research that was going on there as well. Public exposure changed things. And the people who were involved in making those exposures remembered and shared the lessons and the experiences they had. Next slide. And they began to take those experiences and build them into various forms of public memory, whether it is museums and bioethics centers, short films about a study, or books. We can look to these various places of public remembrance to learn some vital lessons about recognizing shared humanity, issues of systemic neglect, and where our routines begin to fail us. And so there are powerful lessons there, but that public memory also has the potential to be limited. It is also born of a certain time and place, and sometimes we need to keep evolving and moving forward in understanding. Our routines might stand pat, but our moral sentiments and our feelings about what is right and wrong keep evolving. And so what I'd like to do in the second half of this presentation is talk about some of the lessons that could be learned from two of these cases, the syphilis study and then the Willowbrook hepatitis study, and begin to apply and think about how they make sense for events in our contemporary period. So next slide, please. So first, I would like to talk about issues of racism and what we know as the Tuskegee syphilis study. That study, for those who don't know, involved 600 African-American men in rural Alabama, who 400 of those men had syphilis. They were never treated. They were studied by the United States Public Health Service for decades that just wanted to follow the natural history of the disease, even after cures became widely available. The study and the resistance and the ways of ending it are remembered at two museums dedicated to that study. The Tuskegee History Center, which was founded by some of the survivors of the study and their lawyer, civil rights lawyer, Fred Gray. And then the Legacy Museum, which is attached to the Tuskegee University's National Center for Bioethics. And they offer two related messages. The History Center, as the top photo shows you, is focused on legal action, the lawsuit that ended the study, but it places that lawsuit against the study against the background of civil rights legislation, or civil rights litigation, and protest. Legal action, the museum argues and teaches us, stopped Jim Crow, stopped various forms of segregation across the United States. The Legacy Museum offers us a slightly different vision. It asks us to recall the legacy of, to think about legacies on multiple levels. The first legacy is the legacy of racism. That racism has impacted communities and places all across the United States, and it impacts them still. That harm still echoes throughout the national body politic. But it also asks us to remember the struggle that occurred during the height of Jim Crow, at the beginning of the 20th century through the 1920s and 30s with the birth of the Ku Klux Klan, and asks us to remember how these organizations like the Tuskegee Institute and HBCUs worked to help communities, help African-American communities across the nation, especially in the South. So the Tuskegee University Legacy Museum talks about the work to sort of help African-American infants with polio, and the various medical and sort of technological and agricultural projects that were used to help make life more livable for those communities. And that sort of lesson of struggling during a time when, civil rights was well decades into the future is a very powerful lesson, and one that I think is useful for us even today. Next slide. Because there are a number of cases where today where racism and the legacy of racism still influences us. And the two of those, there are many, the Black Lives Matter protests against police brutality is a major issue. Because I'm talking about medicine, I'm highlighting two medical issues, which is that Black women are more likely to die during pregnancy than white women, and also the racial disparities in COVID-19 infection. The bottom little picture is the rates of infection in the city of Cincinnati as of last week. And you see African Americans are disproportionately infected. If we look nationally, Black and Hispanic communities suffer greatly. And this is driven by racism, that the legacy of the maldistribution of care and resources still impacts African American and Hispanic communities and puts them at greater risk. They don't receive enough care. They are overrepresented amongst essential or frontline workers who then are experiencing greater exposure to the disease. So how do we apply the lessons of the Tuskegee syphilis study to what's happening today? Well, I think as the History Center tells us, protest and legal action are major actions that we have to undertake. On a level that's sort of obvious, the people most affected have always realized that protest is a powerful tool. The unique addition that I think the Legacy Museum offers us is a lesson about perseverance. This is not sort of standing pat or patience, but recognizing that protest and litigation take time and they take a lot of energy. How do people protesting medical sort of shortfalls and medical racism endure and keep trying to change how that shows up in medical care and medical research? That takes a lot of time and energy. But we also have to consider, what do we do when institutions and especially the government are intransigent? The president said learning about the history, the president of the United States recently said that learning about the history of racism is anti-American. What do we do when there's a refusal to recognize these problems and challenges? And I think the Legacy Museum and the lessons of the Tuskegee Institute and other Black organizations is a powerful lesson for all of us today. I'd like to now switch gears and with the next slide begin to talk about issues of ableism that showed up first at Willowbrook. And the memory work found in various memorials that can be found at the former site of the Willowbrook State School, but also various documentaries and films about the school and the hepatitis study, emphasize again and again two basic lessons. The first is that dehumanization of the developmentally disabled led to the warehousing of the developmentally disabled, led to the horrific conditions that people were kept in. And it is that dehumanization that we need to resist. We need to recognize our shared humanity. Additionally, it argued that making conditions public, making it so that people can't look away, is essential to change. And if you look at it, the lesson of the expose of Willowbrook's conditions by Geraldo Rivera, that's true. Once that happened, there was a sea change in how the developmentally disabled were treated in New York State and across the nation. But this is a case where I think we need to go beyond the lessons provided by Willowbrook and the struggle against that institution and the hepatitis study there. The first is that it still keeps this sense of there are the developmentally disabled and then there are those who are able-bodied. And what disability scholars have been teaching us now for more than a decade is that being able-bodied is transient. All of us, if we have not experienced a moment of disability, are going to eventually be disabled for some part of our lives. And so we can't keep these separate categories alive. We need to better emphasize the shared humanity, the shared collective inheritance of not being fully able to do things that all of us will experience. Second, and I think we've really seen this in the past 4 or 5 years, there is a sizable chunk of the American populace that are willing, or in fact desire, sort of the shaming and dehumanization of others. If we make things public, some people might now enjoy seeing those types of harms. And we need to sort of work to sort of suppress or undermine or end that open celebration of dehumanization that we've been seeing more and more. Next slide, please. The issues of ableism, I think, really speak very clearly then to the coronavirus pandemic. And unfortunately, I had made a slight change to this slide so that the second half of it is not as useful as this version is not as good as what I'm going to say anyway. So apologies if I break from this. But there are 2 situations where I think an unwillingness to consider disability have really harmed things during the pandemic. And the first is around the shortages that happened with chloroquine and hydroxychloroquine. And as you all remember, at the beginning of the pandemic in the United States, the president, following the lead of Elon Musk and several people in tech circles, argued that chloroquine could treat or cure COVID-19. That's not true. It wasn't established then, and it's been sort of shown not to hold, that doesn't work. But this created shortages and hoarding of chloroquine and hydroxychloroquine that hurt a number of people. Globally, chloroquine is still used to treat malaria, and so there was a shortage for malaria treatment. Within the United States, chloroquine is used by people with lupus and other autoimmune conditions to manage their disease. And when all of a sudden it was that able-bodied people now needed chloroquine, insurance companies and medical care providers started telling people with lupus, we're not going to renew your prescription. You'll have to find another drug because we're stocking this for someone else. So there were large groups of people across the United States and the globe who were being harmed by what was happening with the chloroquine hoarding. The other problem was ventilator triage proposals. These have given low priorities to a number of groups, and almost always those with mental and developmental disabilities have been ranked as a low priority. For example, the state of Alabama created statewide policies around ventilator usage if there were shortages, and those with mental and developmental disabilities were at the lowest rung. There's been a lawsuit about that, but and it was never activated as a policy, but still we have to recognize these failures. And some of it is deceptive or misleading communication around chloroquine, but more importantly, a failure to include or recognize multiple constituencies in policy creation, which is an issue that keeps getting brought up again and again every time people talk about policy and why policies fall short. Not enough people were involved. But I think there's a failure to recognize our shared humanity, which is organized around our vulnerabilities and our shared vulnerabilities, and the fact that we can all become disabled in various ways. And this failure to recognize this is one of the problems that we face. So I've tried to highlight 2 of the cases and the lessons that we might learn from them. And there are many more lessons out of all of these studies to involve. There's a richness to the set of cases that I've had, and I'm happy to answer some more questions about that. But with my last slide now, so I'd like to sum up some lessons about communicating around these medical debates, both for lay people and for experts and policymakers. The first two for publics and lay people are somewhat obvious. There is a continual struggle and demand for recognition, a need to shift and change the values that guide our collective actions. And again, these are sort of fairly obvious if you've ever been connected to any sort of social movement in the past few decades. I think a newest lesson here is one about perseverance. We're in a situation where there's a lot of people wanting to keep their heads in the sand about the coronavirus, about racism, about ableism, and the many other isms in our society. And we need to take the lessons from those who've been struggling for years and decades, if not centuries, about how to keep that struggle going. How do we sort of survive when we feel exhausted? As a lot of my friends put it, it feels like it's still March 235th or whatever it is. We're just only a couple months into this pandemic. How do we keep struggling to learn and apply the lessons that we have? For experts and policymakers, there is the evergreen requirement: incorporate more voices and stakeholders. Be deliberate about finding people who have not been involved, who might have a stake in what's going on. But the newest lesson, I think, out of discussing when medicine went wrong is the second, that we need to have humility as experts and policymakers, an ability to apologize when we have fallen short or when our routines might have fallen out of step, and an ability to change. Because it's this absence of humility, this absence of recognizing that ability to recognize that things have gone wrong, that led to all of the sort of debates around medicine in the middle third of the 20th century. If doctors had been able to sort of show a little more humility when it came to research and clinical care, we would have been in a very different type of situation with bioethics and research and clinical regulation today. And so I was told that I needed to keep things between 20 and 25 minutes. I hopefully have done so, and I would like to thank all of you for listening and turn it now over to introducing our panel.
Thank you, John. Your timing was perfect. Thanks for those remarks, not only for a topic that is extremely critical socially, but very close to many of our personal lives as well. I am Greg Loving. I am chair of the university faculty and professor of philosophy at UC Claremont College. I have been able to be a respondent before in Life of the Mind, and it's my pleasure now to help host this event. As Shimao said in his opening remarks, we have invited 3 UC faculty members to respond to Professor Lynch's presentation and to engage the audience in further discussion. This event is meant to provoke discussion, and I am here to moderate that exchange in a new atmosphere for many of us for something like this, but we're going to give it a try. So let me begin by introducing the 3 panelists. So please welcome and help me in welcoming Charles Dorn, Professor of Environmental and Public Health Sciences, Program Director for MPH and Director of Telemedicine. Renee Mahaffey-Harris, President and CEO of the Center for Closing the Health Gap, and Michelle McGowan, Research Associate Professor in the Ethics Center and Division of General Community Pediatrics at Cincinnati Children's Hospital Medical Center and the College of Medicine, as well as the Graduate Program Director at Department of Women's, Gender, and Sexuality Studies in the College of Arts and Sciences. So to begin this discussion, Dr. Dorn will give a brief response, followed immediately by Ms. Mahaffey-Harris, and then Dr. McGowan. After their responses, I'll open it up to the floor for questions. And if the panelists would, when it's your turn to speak, please turn on your camera and microphone. Remember to keep your responses to 5 minutes so that we do have time for some discussion afterwards. I'll throw it over to Chuck. Thank you.
Thanks, Greg, and thank you for the opportunity to respond. Like any graduate student, I took a lot of notes, but now I can't read them. So I think it's important to note, I think going back maybe a few months ago, I got a call from Ann Thompson with WXVU, and she wanted to know why the African-American community in Cincinnati, greater Cincinnati, did not have as much access to healthcare resources through telemedicine as non-African Americans. And you might just posit an answer right away, but I thought for a minute. I said, let me call Dr. Odell Owens and ask him about that. And so he and I are beginning of having a dialogue, and I think Renee and I talked a little bit about this the other day, is that there is this perception that people have limited access because of their zip code, or they don't have access because the internet is slow, or whatever it might be. But if I go back even further, maybe 30 years or so ago, when I still actually work at NASA to this day, we were doing a lot of early activities regarding remote healthcare and access. And some people were a little concerned that, we were using the wrong terminology. And so all these things really kind of focus in on what Dr. Lynch was talking about, is communication. If I communicate in a bad way, I might get divorced, or I might not understand what the student is asking me. So communication is very important. In communicating in this new platform, which isn't really new, some of us have been doing this for 35 years or so, this web-based tool, is that when you're communicating with someone, if they don't understand what you're trying to say, the message gets lost. And so I think a lot of the points that Dr. Lynch was making are very important. And I use two examples just to kind of summarize the leadership or lack of leadership within our community. We hear the president even said the other day out in California after the fires, it's going to get cold soon. I teach a course in global health, and I always show the students a map of the world, what the world might look like in 2111, so almost 100 years from now. And the Gulf of Mexico is in St. Louis. Now you might ask, how is that possible? Well, if all the ice melts, we pretty much have a big problem with the weather and so forth. But if you're not willing to understand and accept science, and it's debatable for sure, there's no doubt about that. There's always this discussion back and forth about what is good science, what's bad science, and so on. And the last thing I would say is I wrote a book, this is a NASA publication, and it's this dialogue between engineers, physicians, and life scientists. They're never on the same page. And this is where you have problems with human systems integration and problems with designing of medical devices, designing of courses, designing a car, whatever it might be. And so I would just close, I know we'll be talking more about some things, but I'll just close with that example is that, we call this the Rosetta Stone, the interface where all these three things come together. In this particular book is the astronaut, but it could be the patient, it could be the student, it could be a political leader, whatever it might be. That dialogue where those three things intersect is really more about the individual we're trying to serve. I'll stop talking.
Thank you, Chuck. I'll toss it over to Renee now.
Okay. Well, good afternoon, Dr. Lynch. Thank you for your really informed comments. I learned a lot myself. I am going to come at this from a communication perspective. First of all, I really appreciated you breaking down the issues of dehumanization, some of the factors in research that have bias, and that race is a construct in that bias. And so, I think as we explore the conversations across the nation, the state, and locally, and the conversation on racism as a public health crisis, and as we begin to look at, research and why we're seeing disproportionate numbers of Black people participating in clinical trials, and the current conversations are surrounding the participation in the vaccine trials. And that stems back to mistrust. And so as we talk about healthcare, we talk about research, and we talk about some of the data that you pulled out of some of the specific studies, mistrust is the commonality in that factor. And so then when you look at communication and recognizing that communication is really stems from our life experiences. And so if my life experience is one in which I have experienced racism, or if my life experience is one that I have not had an introduction into anyone that does not look like me, we can better understand why we're at this quandary, right, in this country, that the systematic and structural factors that contribute to racism, just as you alluded to in some of your comments in your presentation, about, be it the perception, even in looking at social justice, it is about perseverance. It's about aligning with people who have like understanding, maybe not experience, but maybe empathy of experience. And so, I think that I was so excited to hear you. And I was recently on a show with Lulu from Weekend Edition for NPR. And so I was being asked questions by her about, why are the percentage of Black people participating in clinical trials as a whole lower than that of the white community? And I said, it stems back to mistrust. It stems back to how you communicate about participating. And so I think that we have a great opportunity at this point in our country. We've hit a trifecta, right? We have COVID-19, we have the issues of racism, and we have other issues relative to how that plays out in systems and policing and many other factors in our country. And so now we have this opportunity to work to bridge that gap, right? And I think communication is the key. I think the fact that this session is happening today, where we're exploring what do some of the differences look like relative to, looking at that mistrust evolving from Tuskegee. I actually had a professor at Northwestern correct me because I mistakenly said in my comments.
Hello.
Hello.
Good. How are you?
I'm fine. Do you want me to stop talking?
Just keep on keeping on, Renee.
Okay. Okay. Where was I? So my point was that she asked me that question, and I said, well, I think that without information, it's like this whole notion of health is about a marriage of health care and health. And I must say that Dr. Wick-Lofgren really made that analogy real clear to me, right? So that the communication that needs to happen for people to understand why the research and science of trials are important to improving the health outcome. And so that is, again, about communication. And I think when we start looking at communication from the bottom up versus the top down, I think we're going to be able to break some of those silos down. And I guess my main point I wanted to make with you is that I had misinformation in what I described about Tuskegee in my interview with Lulu from NPR. And he corrected me. And he said, I had to correct you because I've heard very often people talk about Tuskegee study being about people being infected with syphilis. And it wasn't that. They were not treated. And I was very appreciative, I was very appreciative of him calling me and saying, hey, I just wanted you to be aware of this. And I said, thank you for correcting me. I wasn't adversarial, and my daughter happens to go to Northwestern. So I said, I wasn't really taken aback. And he said, I didn't want you to feel that way. I said, I didn't, because that's a part of breaking down those communication barriers, right? If he had not done that with me, I may have inadvertently, mistakenly said that again. So I guess that's a wonderful example of what we need to do in the communication side of this conversation, and talking to each other and better understanding what maybe is meant by a statement or what maybe is misrepresented by information that someone may not understand. So I am just really grateful to be able to respond to Dr. Lynch's presentation, which I thought was very powerful. I think the more that we can break down information that is research focused into layman's words, we're going to be able to break down these silos that we are seeing in our country related to health. So I thank you for giving me an opportunity to speak today and respond.
Thank you, Renee. Michelle.
Thank you. So today's lecture, Remembering When Medicine Went Wrong, its title suggests a historical frame, but as Dr. Lynch's illustration of the COVID-19 pandemic shows, This is very much a contemporary issue as biomedical research and the practice of medicine continue to challenge ethical norms. So Dr. Lynch described norms that allow for unethical research practice to arise and to continue, some of which are even sanctioned by and supported by the government. So contemporary norms that give rise to biomedical research and medical misconduct rely on this normativity. And as Dr. Lynch mentioned, challenging these norms may be exacerbated by paternalism, racism, classism, and ableism. And I would add to his list that sexism, heterosexism, xenophobia, and other axes of identity can further exacerbate and frustrate change, particularly when the biomedical research and medical professions inhabit positions of privilege within our society, and their ranks do not equitably reflect the populations that they both study and serve. So we must continually bring historical lessons to bear upon contemporary controversies in medicine. So extending from the examples that Dr. Lynch provided, historical lessons from things such as state-sanctioned sterilization in the United States ought to inform controversies we're seeing in medicine today. For those of you who aren't familiar, state-sanctioned sterilization of populations considered undesirable for the eugenic project and for controlling population size began early in the 20th century in the US and continued until the late 1970s at least. So one strategy to add to Dr. Lynch's list is this idea of using narrative ethics or narrative concepts such as testimonio, as was shown in the PBS documentary No Más Bebés, which documented the course of sterilization of Mexican immigrant women when they were in childbirth in the Los Angeles County USC Medical Center during the early 1970s. This documentary was released in 2016 and was told from the perspective of those women who endured the injustice of coerced or uninformed sterilization. The whistleblower, who was a medical resident at the time at this hospital, and the legal team that brought a class action lawsuit against the medical center, the state, and the US government. The plaintiffs in the lawsuit, Madrigal versus Quillian from 1975, argued that a woman's right to bear a child was guaranteed under Roe versus Wade, which had been decided in 1973 by the Supreme Court. And while this lawsuit ended in a ruling in favor of the hospital due to insufficient evidence of deliberate intent by the physicians to hurt the women, important lessons for health communications and medical ethics can be gleaned from a narrative approach to communicating about what would today be considered a form of medical misconduct. So this documentary illustrated several of the health communication strategies that Dr. Lynch described to promote public remembrance of medical wrongdoing, such as using personal narrative to capture how racism, sexism, and xenophobia has shown up in medicine and systematically disadvantaged immigrant women, as well as strategies that have been successfully wielded to change unjust medical practices and promote reproductive justice, such as the use of whistleblowers, lawsuits, and long-term collective action. So lessons from sterilization norms in the 1970s can be brought to bear on contemporary responses to accusations of sterilization of immigrants without their consent or with inadequate translation services by healthcare providers treating patients detained in Immigration and Customs Enforcement or ICE facilities just this month. Health communication strategies which are being deployed at present include publicizing whistleblowers' complaints, alleging unusually high numbers of hysterectomies at an ICE facility in Georgia, requesting public records related to sterilization procedures among ICE detainees, calling for federal investigations by powerful medical professional societies and leaders within Congress, and calls for collective action to draw public attention to wrongdoing and affect changes in medical practice, including defunding ICE and closing detention facilities where medical wrongdoing reportedly took place. So we're too early in the narrative to know whether and how those in positions of power may have been acting in ways that they thought would better society, as they have in the past, using justifications such as following governmental guidelines, limiting fertility to deter overpopulation or health complications, or trying to optimize individuals or families' life chances or economic opportunities. But medical actions such as coercive or uninformed sterilization belie values that some lives have been and continue to be valued less than others, and some people are thought to be less qualified to govern their own lives, health, and family size. Dr. Lynch reminds us that it's incumbent upon researchers, medical professionals, and ethicists to ensure that the stories of systemic health injustices borne by women, Black, Indigenous, and people of color, immigrants, and LGBTQ identified people, as well as people with disabilities, get told, and that they're continually retold in new ways and to different audiences to ensure that the histories of medical wrongdoing do not repeat themselves. Thank you.
Thank you very much, Chuck, Renee, and Michelle, for those comments and response. We're going to stop the recording now, just remind everyone that.